Good afternoon, everyone. Today, my presentation topic is deep bite and its management. What is deep bite? Deep bite is a condition of excessive overbite where there is a vertical measurement between the maxillary and mandibular in margins is excessive, and when the mandibular is brought into the habitual position or the centric occlusion. So, this is the definition of the deep bite. Now, what is the prevalence rate of the deep bite in our countries? It is the prevalence of the severe deep bite varies between the racial groups, which is as common in Caucasian Americans as compared to the African Americans and Hispanics. So, which are the normal types? In normal occlusion, the bite is 3 to overbite is 3 to 5 millimeter, which is increased than the 2 to 4 millimeter, but which we can consider as a normal. But when it is increased up to 5 to 7 millimeter, we consider it as a moderate deep bite. And if it is more than 7 millimeters, so it covers the most of the lower incisors, it is a severe deep bite. So comes to the classification and the etiology. There is a developmental deep bite and acquired deep bite. In developmental deep bite, there is a skeletal deep bite in which there is a horizontal growth pattern and maxilla and mandible are both together more. So there is a skeletal deep bite. And then comes to the dentoalveolar deep bite in which there is supra-eruption of the incisors and infra-eruption of the posterior teeth or combination of both two. Now comes to the acquired deep bite. In acquired deep bite, it is associated with the another conditions like lateral tongue thrust, early loss of the deciduous teeth, and wearing of the occlusal surfaces. So there is also development of the deep bite, which is acquired one. Now you can see in the figure. First one, let's discuss about the skeletal deep bite, which is usually caused by upward and forward rotation of the mandible. You can see in the figure B. There is upward and forward rotation of the mandible which create the deep bite. In figure C, you can see there is a downward and forward inclination of the maxilla. And the figure D, you can see the combination of this both two. So there is development of the skeletal deep bite. It is usually characterized by decreased lower facial height. If you can see, that is usually with the class 2 division 2, which there is procline lateral incisor, which is overlap the central incisor. You can see the growth pattern, which is normally it is horizontal, and you can see cephalographically there is a mandibular angle is low. It is characterized by, if you see cephalometrically, the both plane are almost parallel. So the mandibular plane angle is decreased, which shows there is a skeletal deep bite and the horizontal growth pattern. See, there is a cranial base, and if you mark the proportion, that is a Jarabeth ratio, that is the height between the nasion to menton, and there is a posterior height. So there is a reduced y-axis and there is also reduced the Jarabeth ratio, which shows the skeletal deep bite. These are the cephalometric finding like Jarabeth ratio, y-axis, there is an increased ramus length. These are all the cephalometric point which suggest that the patient has a skeletal deep bite. Now comes to the dentoalveolar deep bite. How we can identify whether it is skeletal or dental? So there is absence of skeletal complicating feature, but there is a dental features, that is over eruption of anterior and infra occlusion of the mole. So this lead to dentoalveolar deep bite. There is usually seen in the class 2 malocclusion. There is also increased overjet, which causes over eruption of the lower anterior, and there is creation of the increased curve speed. Infra-occlusion of the molar, which is usually occurs due to partially erupted molar. There is large intra-occlusal clearance. Sometimes there is development of the lateral tongue thrust. So due to lateral tongue posture, they prevent the molars to erupt. And also there is premature loss of the posterior teeth. This leads to infra-occlusion molars, and further it leads to development of the dentoalveolar deep bite. Now comes to the soft tissue deep bite, which is often associated with the class 2 hypodivergent patients in which they have tendency, there is a strong mandibular elevator muscle as there is a horizontal growth pattern, high mentalis activity, which you can see. There is a deep mentolabial fold and evertail lower lip. This is the common feature of the class 2 division 2 malocclusion in which we can find the soft tissue deep bite. So how will you diagnosis? First one, you can diagnosis with the clinical examination. Then you can observe the study task, then you can find out with the cephalometric finding. Now comes with the treatment modalities. Let's start with the mechanical consideration. First, for correction of the deep dentalvular deep bite, we need to intrude incisors, we need to extrude the molar, and we need to proline the incisors so we can get the both proline and we can correct the deep bite. Now, we need to consider whether the patient is growing or non-growing. What non-growing, we need to either go for surgical or micro implant. Then aesthetic consideration. What are the treatment challenges? How will we stabilize what we have corrected? And conclusion. So first one is the intrusion of the incisors, which is normally there is over eruption of the incisor. So we need to intrude that. So we can use the continuous arch in fixed mechanics. Even we can use the segmental arch technique, and sometimes we can use the high pull head gear. By using that vertical force, we can intrude the incisors. Now we can also encounter the another thing to extrusion of the posteriors, in which there is 1 millimeter extrusion of the posterior teeth causes 1.5 to 2.5 millimeter reduction in the incisor overlap. This is a result which different studies have shown. So it is normally indicated when the patient has short facial height, there is a more top speed, and the incisor displays ranging from normal to minimal. So extrusion of posterior is required in this type of the patients. Then proclination of incisor. When we find there is a retrocline incisor in normal deep bite. So we need to procline typically in class 2 division 2 patients and sometimes in class 3 patients. Now, what are the strategies to extrude the mold? First one, in the fixed orthodontics, we can change the height, vertical height of the brackets. So we can do with that at least 1.5 to 2 millimeter. Then second is the leveling of the dental arch by reverse stops P wire. So we can add little bit reverse stops P in the wire and we can engage that into the arches and we can extrude the molar. Even including of the second molar also sometimes fixes the problem. Then we need to give anterior bite plan and sometimes we can use class 2 elastic also to correct the deep bite. Now, whether patient is growing and non-growing, whole treatment is depend on that. Because if patient is growing, we can use some removable appliances like anterior bite plane. Sometimes we can prefer the 2 by 4 appliances and the utility arches to correct the deep bite. You can see in this figure. This is the first one is the intrusion utility arch. It is engaged in the four anteriors. There is vertical band here and it is again engaged in the auxiliary tube of the posterior band. So if we not fixed here, it is in the gingival direction and we pull that into the bracket slot and it gives an intrusive movement in the incisors. This is again retrusion utility arch and it is a protrusion utility arch. So these are the arches we can use to correct the dentoalveolar deep bite. This is the article which suggests the utility arches, which is the integral part of the interceptive orthodontic treatment. Now, this is used in the growing individuals. But when it comes with the non-growing period, the orthodontic surgery is the main treatment option for the severe skeletal problem. But sometimes nowadays, micro-implant, development of the micro-implant and ISERs is also used to correct the deep bite. So, we can we can treat the individual with a minimal intervention, sometimes lead to compromised result. So sometimes it's a lengthy treatment, reduce aesthetics, periodontium may be compromised, root resorption may occur, even orthodontic surgery at last we have to go for surgery. So surgical management of deep bite is very important when we consider there is a plan for orthodontic surgery. Now, what aesthetic consideration we will take care? So we have to check the upper lip line it in relation with the maxillary incisor because we want to give the patient the youthful smile. So also, which are the contraindication of the intrusion? There is a low lip line. The teeth visibility is already not there. If we intrude more, which gives the older appearance to the patient, younger patient. So we should not prefer that. Even reduce lower facial height. In those type of the patient, also we cannot intrude more. In those type of patient, we need to uh, try to erupt the posterior teeth. Now you can see the figure. This is the lip line and incisor relationship. Now, what treatment challenges we normally encounter when we treat the severe deep bite patient? Sometimes addressing the limited objectives to resolve a specific patient complaint, reduce treatment time, or to avoid surgery. Sometimes there is more weightage which is given to the aesthetic consideration. So patients are more demanding the aesthetic result which is not clinically possible. So we have to ask and inform the patient everything before starting the treatment. And if we require more than orthodontic surgery is required, we have to explain everything about that to the patient. Now, what side effects we try to minimize while deep bite correction because it's a very tricky to treat this type of condition and challenging also. So we need to take care about tooth resorption, periodontal complication, even TMJ dysfunction as we are changing the patient's bite. So which usually face problem in the TMJ. Sometimes clicking sound and deviation may develop. So while treating the patient, we have to take care of all these three problems. Now, what are the limitations of the treating deep bite? First is the nature of occlusion. Sometimes there is a missing teeth. There is mutilated occlusion. Sometimes there is missing molar. In this type of patient, we cannot promise them to treat them 100%. We can give them 100% result. Sometimes patient has compromise in dental health. So many restoration, caries, loose resorption, which is already there. Even patient has TFO, periodontium is not good. In this type of patient, we cannot treat them efficiently. Then mechanical limitation. Sometimes there is difficult to space closure in which basically extraction space. In this type of patient, we cannot treat the patient efficiently. So basically the success of the treatment, orthodontic treatment of deep bite patient is basically depend on patient's compliance in growing individual, whether patient is ready for headgear, ready for functional appliance or bite plane or elastic. So patient appliance is very important. Now, how once we get the result, it's very tricky to stabilize that result also because the patient is hypodivergent face, they have hyperactive mentally, even masseter muscle force is very strong. So we need to stabilize that very efficiently. We have to give long time retention, which bite plates we need to give. So while stabilizing, we need to contribute to certain factors like growth, muscle strength, muscle adaptation, and original musculature. So, what these are the guidelines and how will they stabilize the corrected deep bite? First, treat a developing deep overbite early. So, as soon as we see the patient, we need to correct that. Second, avoid extraction because there is a high muscle force in this type of patient. It is very difficult to close the space. Long-term retention is required, and even bite plane can be used even after the treatment. Then, so how can we conclude? See, deep bite is very common problem nowadays. We can see in the children due to high carriers prevalence rate and even periodontium problem. So we have to treat by keeping in mind with the proper diagnosis, aesthetic consideration, stability, and long-term retention. Thank you. Thank you for your patience.